right. Hello, healing warriors and healers. Welcome. Today's a special day. I know a lot of people who experience post-COVID symptoms, like myself, have trouble with exercise intolerance, fatigue, high heart rate, and it makes it incredibly tricky when we're trying to figure out how to exercise because we want to build up our stamina and our strength. But then when we have all these symptoms, it becomes much more complicated and we can often tend to crash afterwards. So today I have a special guest, and she is an exercise physiologist who will be sharing her expertise with us in working with people who have these symptoms as well as many more. And Julie Tracy has a Master's of Science in clinical exercise physiology and is the lead exercise physiologist at Brigham and Women's Hospital in Boston for the dyspnea clinic, which is shortness of breath. And she's also certified as an ACE health coach and in precision nutrition level 1. And she will soon be certified as a women's coaching specialist through the Girls Gone Strong, which is an amazing organization dedicated to women's health, strength, and empowerment. So welcome, Julie.
Thank you.
I'm so glad
Happy to be here.
Yeah, thank you so much for spending time with us today.
Of course.
So the question is, can you tell us about the work that you're doing at Brigham and Women's at your program?
Definitely. Yeah. So I'm the lead exercise physiologist at Brigham and Women's. I was hired like 9.5 years ago to help out with the invasive cardiopulmonary exercise program. It just started. We had the at Mass General, and then the doctors moved over to Brigham and Women's to expand the program. So kind of my main job is we expanded that. Now we're doing much more testing with the invasive test Tuesday, Wednesday, Fridays. And then we do some work in the clinic as well with patients who have unexplained shortness of breath. And that could be also fatigue, exercise intolerance, the shortness of breath, dizziness, now kind of chronic fatigue syndrome, and that kind of deal. So we try to figure out what's going on. And then maybe 5 years ago or so, we had a really terrible winter, and we had to cancel a lot of patients. So I had a lot of downtime. And this is where kind of this exercise program was created and has evolved kind of since then to help people actually put in place an exercise program and have accountability, and versus doctors are kind of busy, don't have time to actually follow up, versus just kind of telling people to exercise. So that's kind of what we do at the hospital.
Thank goodness for downtime, I guess, in snowstorms.
Yeah. I mean, this was before COVID. It was a really bad winter. It was like 100 inches in like 2 months.
I remember that. So you mentioned an invasive test. What is the invasive test that you're referring to?
Yeah, so it's quite an involved exercise test. So a lot of people know what a stress test is typically, but we're trying to figure out why people are short of breath. We're not looking at, a lot of stress tests look if they have cardiac disease, so we're not looking for that, the blockages in the arteries. And what they'll do is they'll go to the cath lab and get a right heart catheterization. So that's a catheter that goes down the jugular vein and into the heart, and you're able to measure pressures of the heart and also the pulmonary artery pressure. And after they do that, we set them up and we exercise them with the catheter, and they also have an arterial line to measure blood pressure and to take blood from the radial artery. And the idea is that most of these patients we see are symptomatic with exercise, not at rest. So they do the right heart cath. Usually those are pretty normal numbers. And then we exercise them to their max and take pressures and draw bloods. And then we have everyone's favorite, the mouthpiece, where we measure all the breathing data and hopefully most likely can figure out, why somebody is short of breath or limited in general. And it's complex.
This is a CPET test?
Yeah. So this is the iCPET, I guess you can call it. And then a cardiopulmonary exercise test is just without catheters and just the mouthpiece, where they measure their VO2 max and all the metabolic data from the mouthpiece, the breathing data.
Yeah, and I had the eye CPAP just to let people
Yep.
know. And actually,
You had both. You had the non-invasive first, yeah.
oh, I've been
You got a
aware
little
of it.
glimpse into what it was.
Right, and I gotta say it was very helpful because so many other tests nothing was coming out conclusive. But this more invasive test, we finally were able to determine that I have preload heart failure from post-COVID, meaning there's just not enough oxygenated blood coming to my heart. So finally, I was able to get diagnosis and get medication that is finally starting to help me. So it's invasive, but it can be very useful for some people, and then also help people come up with a plan, such as an exercise plan.
Yeah, so it kind of dives a little deeper than kind of a traditional exercise test. And like you said, a lot of people will have years of testing and they all come back normal, and we'll likely, find something at the very least. So, and also, we look at, it looks for more than one type of issue. So you can say, oh, well, you definitely don't have heart failure, or you definitely don't have pulmonary hypertension. So it's kind of comforting, I think, for some people to kind of eliminate some of those kind of, when they Google, the scary kind of diagnosis. So,
yeah, right. And
so that's kind of what we do.
There's a lot of people that post-COVID were getting diagnosed, such as myself, with dysautonomia or autonomic nervous system dysfunction. And I know you work with a lot of people before COVID with dysautonomia. And I was just wondering, can you explain what that diagnosis is to people?
Yeah, so dysautonomia is kind of an umbrella term for, a disorder of the autonomic nervous system. It's kind of like a malfunction of the autonomic nervous system. And the autonomic nervous system is basically, it controls things that you don't have to think about. So that could be heart rate, blood pressure, temperature control, digestion, and a whole lot of other things. And it's interesting because people with dysautonomia, might have a lot of features and might not have digestion problems, but might have POTS or orthostatic issues, or, but some people have all of the things and some people only have certain aspects of it. So the invasive CPAP that we do, a lot of these patients, what we'll find is incredibly low filling pressures. And that's basically the veins in the legs squeezing up the blood to the heart. It's like almost non-existent. It's so low. And that was termed preload failure. I don't remember who exactly termed that. So that's kind of like a feature, I guess, of dysautonomia, is that kind of inability to pump that blood back up to the heart and also the head. And that's kind of why people get so dizzy. Mm-hmm. So, so dysautonomia it's just a broad term, and some people have chronic fatigue, some people don't. So it's very generic, but it can involve a lot of different types of issues, medical issues.
Which would make sense because the autonomic nervous system is so complex and so many different parts of the body and systems even.
Exactly.
Unfortunately.
Yeah, unfortunately, right? Yeah, some people have incredibly difficult like digestion issues, and that can kind of lead to other nutritional issues, right? If you can't eat or whatnot, and some people pass out the moment they stand up, and so it's definitely complex and very life altering, definitely.
Right. And then you mentioned POTS. What does that POTS stand for?
Yeah, so POTS is a postural orthostatic tachycardia syndrome. So some people, when they stand up, and this could be, just slowly or whatever it is, their heart rate goes way up, and their blood pressure goes way down. Which shouldn't happen, right? So when you stand up, your heart rate should go up a bit, but your blood pressure shouldn't tank, and you shouldn't pass out. So it's kind of an abnormal, autonomic, nervous system response. And some people have that feature, and other people maybe don't get orthostatic, but they get dizzy and their heart rate goes up. So it really varies person to person.
Now, are you working with anyone who is post-COVID or having post-COVID symptoms, but not dysautonomia?
Yeah, that's a good question. We have had maybe a handful of post-COVID patients to go through the invasive CPET, but we have not looked at the data. I don't think there's enough people yet that we've gotten to kind of take a look at the data. But that is something that I know we're going to look at to see if there's any differences with like dysautonomia patients. Just from like my memory, I'm pretty sure that there were a few that didn't have like this preload failure. But don't quote me on that. We'll have to take a look at everything.
So it is recorded. So
just from memory, I think the first person didn't.
So I'm curious, is there a difference between the symptoms and even capacity to exercise with people who have dysautonomia?
Yeah, it can vary actually quite a bit. Sometimes we'll have athletes come in who are like, I used to run marathons, or I used to do this and that. I used to be, a collegiate athlete or whatnot, and now, I can't do as much. But their VO2 max is still, like their exercise capacity is still really high. Maybe it's not as high as it would have been, unless they had a previous test. And then there's some people who, maybe weren't athletic, or maybe they were more sedentary, and so their VO2 max maybe started lower, kind of pre-symptoms, and now they're even more limited. And I've also found the severity of the syndrome varies too. It can be very severe, like bedridden, to people who are still, running, but maybe, have symptoms and maybe can't do as much as before. So it's almost like a spectrum, and I feel like everything kind of has a spectrum these days, but it's definitely, that's what the VO2 max test kind of helps kind of quantify that. You can kind of quantify how severe the disease can be.
Mm-hmm. So how do you go about then creating a program for somebody, especially, there's so many different people, different symptoms, it sounds like that can be very complex.
Yeah, no, that's a good question. So way back when I first started, I was like, what do I do? How do I help this group of people? I was focusing on this dysautonomia because you can't just tell them to exercise, like you have to give them a little more guidance. And the research back then, it's still kind of limited, but there was a group in Texas that did a POTS study. I forget who exactly, and it was a little more aggressive as far as exercise goes. And it was like, you either do this or you don't do it. So it was, but obviously for the research. And there was a lot of dropouts, and there was also a lot of people who finished it. So it was kind of mixed. And then actually a patient of mine sent me some info about a doctor in Florida, Dr. Kilmes, who specializes in chronic fatigue syndrome. So I kind of learned kind of all the stuff that she was doing, and kind of came up with like a combo kind of program, kind of taking kind of the research that's out there and kind of making kind of our own thing. And I think the biggest thing is it's very individualized. So sometimes we'll start people more aggressively because they're okay with it, and sometimes we're talking about how to pace everyday life. Mm-hmm. So not even exercise, just activity. And so typically what it's evolved to, because it definitely has changed over the years, hopefully for the better, is we'll send out a few questionnaires just to help kind of get an idea of home life, like how are you day to day. And usually we'll have some data from like a CPET. Like I remember with you had the non-invasive at the very least, and then usually we'll have an invasive CPET to go off of as well, to kind of help gauge kind of the fitness that they already have, and kind of the severity of the data, like the pressures and stuff. So kind of combining that, you kind of get an idea of where to start. But then usually starting COVID, actually I started doing more phone calls because I had a little more time. And so the phone calls were great because you could really kind of talk to the person and see what they're comfortable with. Because some people who maybe don't have post-exertional malaise can start with more exercise and just kind of need a little more guidance, kind of managing their dizziness or their shortness of breath. Mm-hmm. But, you know, if somebody has severe post-exertional malaise, it's kind of a conversation about comfort and, you know, maybe even just starting with some breathing exercises or pacing or just a few strength exercises. And then we also do some aerobic recumbent. So we like to start with recumbent, so you're laying horizontally. So that could be recumbent cycling, rowing, or swimming. And then all the strength exercises we give are also in that position. And the idea is that position, you're not fighting gravity. So the blood is able to get back to your heart and your head a little easier, so that you can hopefully do more. And it's kind of a little, I hate to say this, but it's a little trial and error. I always try to start on the lighter side. I want it to be easier because we'd rather have our patients be more consistent and doing less exercise than to be like, oh, I feel great today, I went all out, and then I'm out for like 2 weeks. Mm-hmm. Which is, so it's kind of like starting, helping them start somewhere and then kind of building up very slowly. Some slower than others. Mm-hmm. And also, I had one patient who was like, oh, should I do more? Like, I'm really anxious about it. And I'm like, if you're anxious about it, then, no, because that's going to make it, anxiety is going to make everything worse. And right. Kind of helping people kind of just figure out what, how to kind of listen to their body. Because I can't tell you, mm-hmm. You're the one that's going to know, if it's okay, but that just takes some time to figure out too.
Right. So do you you're saying that you tend to start people in recumbent, mm-hmm. recumbent bike, it could be swimming, and then you also lying down and doing even light strengthening, lying down. So how do you figure out how much time, for example, like the recumbent bike to start with? And then how do you figure out how to move on?
Yeah, no, that's a good question. It's kind of complicated, but mm-hmm. So Dr. Kilmes had this kind of formula. This is what I started with. And she was like, how many minutes did the exercise take to get to anaerobic threshold? And that's kind of where you start. That was kind of the formula I used for a while. And kind of the more patients I saw, a little easier it was to kind of gauge. I almost kind of do even less than that now, I feel like, because I've been seeing a lot more chronic fatigue. Mm-hmm. And it's kind of a delicate line. And so you basically kind of interview the person and try to figure out, what have you done? How did you feel, when you did it? And I feel like most people just start with like a minute or two mm-hmm. and then rest, and then it's like, okay, you can do that. Okay, great. Then we'll do a little bit more. We'll add like a minute mm-hmm. or I've even started people at like 30 seconds, So it's kind of just a conversation and a little trial and error. And there's a few tools. I'm not going to get super detailed into this, but there's a few tools that you can use. Some people are really into heart rate tracking, which is something I can help them with. Some people that causes too much anxiety, looking at a number and things beeping at you. So we use just like a RPE scale, which is a rate of perceived exertion, so just kind of how you feel. I think the heart rate is a great tool for depending on the person. I also think it's a great tool to just kind of be in tune with, how you feel too. So it's kind of all of those things. And life happens too. So I had some patients who are like, oh, I had to spend some time with family. I had to do this. It took a lot of energy. So I had to miss some days, and that's okay. Right. It's all about kind of managing your energy. And so you might repeat a week or go back a few weeks. I remember I had this one patient who started with a minute of exercise and then a minute off and then a minute. And 3 years later, she is now doing like 25 minutes. Mm-hmm. But she repeated a bunch of weeks, and she was able to kind of figure out kind of how she felt. Okay, I definitely need to repeat, or I need to take some time off, restart this, and it took a long time, but I was very impressed with the kind of the determination, and you have to have a lot of patience, I think, and that'll go a long ways. So
yeah, I think that's important that you mentioned patience and repeating. Like, there's nothing wrong with repeating a week, or I've repeated the same week, I think, like 3 times, because life does happen, or you can have a procedure that you need to recover from, or you're just not feeling well. And so you don't want to be pushing yourself. It's like our immune system, our cells only have so much energy. It's just like a car and a fuel tank. And when that fuel is done, you can't keep pushing, because you're going to burn out. And it's learning to really not even just respect the body, but work with the body. Like, it's teamwork with the body.
Exactly.
Just having patience. And I know people with fibromyalgia, like a lot of times I'd say, okay, after you work out, make sure you have recovery time. And I feel like even with this program, it's having recovery time in between what you're doing. Like if you do maybe one set of like very light weights, if weights at all, then you have like a little recovery time, and you keep doing that to see like what works, what doesn't, like the trial and error.
Yeah, and I even have some people who do their intervals like 1 in the morning and 1 in the evening. Like, that's how long of a recovery time, and some people have that ability to, time wise. Some people are still working, some people aren't. It's just not cookie cutter at all. And I think that's kind of the biggest thing. And I'm happy to, because Dr. Systrom, has been, we recommend exercise and recombinant cycling or this and that, but he doesn't have time to like really dial in kind of, what to do. So that's kind of where we, me and another girl, Katie Lewine, where we kind of can really focus in on a program that, can really help and work for somebody. So.
Yeah, and Dr. Systrom is a pulmonologist. I actually seen him. Was that?
Oh, yeah, sorry. But a lot of people might not know. Okay. In this world, actually, a lot of people know who he is.
Yeah, actually. You can even just search his name.
He's got a YouTube.
Yeah, I was going to say you can find him on YouTube. Right? Great. And you even mentioned exertion, and I remember like saying very easy. It's almost like not even very easy, but super easy. You start with, and
it's some people. It's a matter of bringing them down. Like, hey, you need to do a lot less.
Yeah.
And then some people, it's doing, they're not starting from a lot more. So it's a little different kind of scenario. And some people have had really bad experiences with exercise. Some people did like a program, I forget, I don't really know the name, and they're like, it destroyed me. So they're very hesitant, and I would be too. Because I think it gets a little bad rap in this world. And that's why I think kind of individualizing the program, and it's not no pain, no gain. That's a very old school kind of thinking. And that just kind of ends up hurting people. And so kind of really tailoring a program to what the person needs is kind of the key. And that's kind of what we use a bunch of different methods, but that's kind of the biggest thing. Recently, we did a conference call with the WorkWell group. That would be Stacy, forget her last name. And they're in California, and they specialize in chronic fatigue syndrome. And they do this like 2-day CPET, where you do a CPET one day, CPET the next and see how the big of a difference for the post-exertional malaise. And so we talked a lot about what they're doing, and they gave us a lot of good ideas, kind of for the more severe patients, and then it kind of justified some of the stuff we are currently doing. And I think it's a good idea to kind of be on the same page as some of these other kind of groups that are out there doing this. So
yeah, it's nice everybody's networking with one another.
Yeah.
Yeah. Because I think this is very, very complicated. It's not like, you know, we're training for, but train for a marathon right now. We're really we're retraining our heart, we're retraining our immune system, we're retraining our body. And it takes time. And I sent you the writing. It's about, you know, if you send a soldier out into a battle and he comes back wounded, well, you're not going to send that soldier right back out again. You're going to give that soldier a lot of time to recover, to recuperate, and even giving nurturance and even self-compassion, and being compassionate with yourself. Like, it's okay not to be doing so much, because what you're doing is actually so much, and you want to live life and not be crashing, which is very difficult. It is so much trial and error. And I know
it's a difficult thing. That's why I like hearing about you guys talk about like the support groups, and you know, you have people you can talk to who get it, you know, and that you're not the only person thinking, you know, that you're crazy, or you know, that they're, you know, that no one can figure out what's wrong, or so and that's another aspect of kind of the mental health that is important too.
Yeah, and I think those Facebook groups, I do have them at the resources on my first week of the program. They're wonderful groups because people will show what they've been doing and how long it took to accomplish it, but it gives a lot of hope to people, and how it's okay to pace yourself very slowly, because, you know, it's just, think about it this way, like one pebble at a time can create a mountain, right? You can that feat that you want. It's just taking that time for yourself. And I know I started working with you because, you know, I did my own research and just did my own experience in rehab. You know, I started doing the lying down on the ground and doing exercise and trying to build myself up, and starting 2 minutes to walk a day and building that up. But it was very difficult because my heart rate was so high. So it was and it was almost like I just didn't understand where should my heart rate actually be, because it, excuse me, no matter what, it's high. So it was very helpful for people who like to look at their heart rate to be able to work with someone. All right, we really need to work here. And we kind of compromise at first. Excuse me.
We do that a lot. It's okay.
Well, that was my resting heart rate, but I was able, but it was nice because you gave me a goal of where I really want my heart rate to be, even though it was still high, but where I wanted my heart rate to be. And so I had something that was kind of tangible for me, and so I backed off even more. And you even said we're going to be backing off. But I backed off and slowed down even more so I could really try to maintain that heart rate and not crash, and start understanding more about the symptoms. And now that I'm on medicine, I'm still tracking my heart rate because it does go up, but I recover faster. So for me, that works well. But it's still important, even without looking at your heart rate, to monitor the symptoms as well, because you're not always going to be monitoring your heart rate necessarily when you're, you know, out.
Yeah, the data can definitely help. We kind of traditionally, I mean, we can definitely give heart rate, you know, below AT, right, which is a lot of people ask for. We have like a zone approach, and a zone 1 is below 64% of your max heart rate, and that max heart rate is actually measured in your exercise test. And because, I mean, they don't translate exactly, right, because you're doing a little different exercise, but it is something to start with. And zone 1 is typically even lower than your anaerobic threshold heart rate. So it's even kind of being more careful. And everyone's anaerobic threshold heart rate is different. So that varies quite a bit. And if you can kind of push that, you know, higher and higher eventually, and that's kind of the idea.
And I think to let people know too is, for example, of what I'm working on. I think we're in month 3, and so now I'm starting. I built up to walking 5 times a day, 3 times a day for 5 minutes, and then building up to 4 times for 5 minutes, and then getting comfortable with that. So that could be a couple of weeks, and then building that up. And then I would do walking on one day, and I do use a recumbent bike sometimes also instead of walking. And then on another day, doing some exercises, but then also putting rest in between. Like on the next day would be a rest, like having some rest days during the week. And then now what I'm working on is just like I have 8 minutes of walking a recumbent bike, and then I have recovery time. And later on, what I'm going to do is actually start incorporating some strengthening exercises. But again, resting and having recovery time. And that was 3 months with us, and I was working out even before then. So I would say it's been 6 months I've had this. So it's been 6 months when I'm actually able to get this, just to give people an example of, the amount of time it can take, which is fine because it's what's right for you. And what helps you get stronger, and again, not crashing at the end. And again, what you said, patience.
It does take a little time to kind of figure out kind of what works for you. And when you do, it's funny because like I start to kind of hear from people a little less and less, but like not in a bad way, but just because they kind of just know. Yeah. And then all of a sudden I'll get an email like, "Hey, I'm ready." And I'm like, "All right." And it's like, like I can't tell you, right? You're the one that, and it gives you kind of something you're in charge of, right? I mean, your doctor, we can help you and guide you, but ultimately, you're the one that's going to be doing the work. So,
maybe that's another positive about having to go through an illness is that, we learn to get more in touch with our body. So a lot of times we're not taught that. So
no, not at all.
We're really learning to understand not just our symptoms, but how our body works and what our body needs and when our body needs to rest. And even if we're not ill, that is something that everybody really needs because people get burned out.
Yep. Especially these days. People work 80 hours a week and have families and have to take care of their kids and have to drive their kids to sports and have to work and have to, and they kind of don't have a chance to, think about themselves. And so it's just kind of a society type, like we should praise people who kind of take, I guess self-care is kind of a silly word, but who kind of take the time to kind of take care of themselves so that they can take care of other people better.
Right. And everybody needs recovery time. But
totally. Athletes are so bad at recovering.
Yeah, and I've seen athletes that have really gotten hurt by it too.
Yeah. Yep.
Yeah. Right.
Exactly. Yeah. The hardest thing for athletes is their recovery day. They go out and do like a hard workout, and then they feel bad on the day that they're supposed to do a hard workout.
Mm-hmm. Right. So is there like an on average, or how long do you tend to see people?
Oh, good question. It super varies, kind of like every other answer I've given you today. Some people don't even answer my email about the questionnaire, so it never even really starts. And some people I usually give like 2 months of a program and talk to them about kind of the repeating and if they need to. Sometimes that's all people kind of need, and then they kind of do their own thing. Other people like kind of the accountability, so we'll kind of check in. I'll help them kind of increase it, answer questions. I think I just got an email from somebody, I swear, like 3 or 4 years ago we started, I think I'm on like month 15 or something like that, which, at a certain point, sometimes the intensity does go up. It really depends. And it also depends on people's goals. Like I've had one person was like, I really want to hike again. So we kind of tailored that to how hiking would be. And some people just kind of want to not have crashes and just feel better. So I don't really need to see, that particular person for that long, but I'm always, kind of here for like as questions or resource, or just to kind of feel like you're doing great. Kind of a reminder, a cheerleader, I guess you can say. So that kind of varies quite a bit. I don't take it personally if you don't need me anymore. So that's usually a good thing.
Right. But it shows how individualized the program is for each person. and how much it hones into the person. I was wondering, well, because I asked you this before, like, so when do I get to do cardio? I'm like, well, you are doing cardio, you're walking.
Yeah, I was like, well, you are doing it.
Again, patience, right? But how do you know? Is there a way to know when somebody's ready for? I'm not even going to say running. I'm going to say maybe something a little easier on the body, like using the elliptical machine or an upright bike.
Yeah, like an upright. Yeah, usually, some people don't have symptoms like walking. So we actually, and they really want to walk. We'll start with, kind of like a combination. Mm-hmm. But if we start just recumbent, I usually look for, consistency, especially, and kind of an increase in that kind of lower zone, mm-hmm. Zone 1 or even zone 2 sometimes.
Zones, yeah.
And confidence. People who are like, yeah, like I feel, ready and I don't feel anxious about it, and, I'm not worried about it or anything like that. Mm-hmm. And it's kind of it's just a conversation that we kind of both agree on or whatnot. And not everyone even needs to kind of go to that point. And some people are more motivated to kind of include that type of exercise. So,
and it might even
again, it just depends. Answer to all of life.
Right.
Depends.
And what I tend to do sometimes too, if I'm going to progress to something, I like to make sure it's a day that I don't have that much going on. I don't have to worry about how I feel, or even the next day, especially with something. I mean, I'm not doing I'm not doing the elliptical machine, but I can see by the time I would be ready, I would make sure that day and the next day I have some, plenty of recovery time, because it is new to the body, even if you've been progressing up to it. And, there's been so many times I've walked 1 extra minute and I've crashed, which shows how sensitive a body that's healing can be. It takes tons and tons of energy for the body and the cells, immune system to heal. It's a lot of work on top of working out, as well as taking care of family or working in the house and cleaning. There's just, everything takes energy. So,
mm-hmm.
It's back to kind of, you mentioned pacing even. You mentioned pacing, which brings me to, so when you start with someone and you're basically just focused on pacing with their activities, the daily activities, it sounds like, how, can you give us an example maybe of someone that you worked with, or how you would go about doing that if they're not even, they don't have to be ready for working out, but they're ready for, they really need
So, there are activities of daily living that you have to do, right? Like eventually you have to shower. And, maybe you don't have the luxury of somebody else cooking your meals or getting food ready. So kind of treating, it's kind of like the same thing as the exercise I give. Okay, it's 1 minute, exercise, making sure you're keeping it, below this heart rate, and then rest. So if you're standing and cooking, have a chair next to you so you can take a break. If you're tracking your heart rate, if you notice it going up, you start to feel, take a break. I know it's not super ideal. A lot of people, like if they're at work, it's kind of hard to do that kind of thing, but changing a little something is still better than kind of what you were, before. So kind of starting with kind of managing that when you can is going to help. At least, it's a good start at the very least. And, some people can't do, the exercise. So that's a really good spot to start with. And rather than me being like, I can't do anything for you, which is not a very great thing to hear. It's like, okay, instead of jumping into exercise, which seems like not a very good idea, let's talk about, this, and this. And so there's kind of always something we can at least talk about, or even managing stress, right?
Yeah.
And, I dabble a little in nutrition. I can't, necessarily treat your disease with nutrition, but I can advise people, how, healthy diet and whatnot. So, which is also kind of a nice thing if you can't focus on exercise, you can maybe focus on, your nutrition and, a good sleep routine, or like what they call sleep hygiene these days. Or even breathing exercises, right? Which is something that you specialize in. So there's always something that, you can kind of start with.
Yeah, and as an occupational therapist, we work on a lot of that too, the pacing and even setting a timer. And we can, suggest some nutrition recommendations as well. And even, when I take a shower was really difficult. So take a shower, I would rest. After every activity, I would rest. And I actually had, my friend had the meal train. If people don't know what that is, the meal train is your friends actually can sign up bringing food to you, because I could not. And eventually now I can heat up food. So it's
that's nice.
But then I rest. So it's really, it's difficult. You really have to plan your day. So now I take a shower at night so I can rest. I don't have to worry about that as being my morning routine. And you're talking sleep protocols, like having AM and PM protocols.
It's just a different lifestyle almost. Kind of figuring out a new routine, a new kind of lifestyle, which is really hard to do. It's hard to change something you've been doing forever.
Right.
But a little bit at a time kind of adds up, and then you kind of are managing your symptoms a lot better and living, better and kind of more, you're not as, down about it, or, you can start to kind of be a little, feel better about kind of your disease and how you're managing it.
Yeah. So more empowered, and even it can help decrease anxiety. Yeah. Well, thank you so much. Is there anything you'd like to add?
You're welcome.
Come to a close.
I feel like I could talk about this a long time. I guess the kind of big picture is to have patience, forgive yourself, right? Don't be so hard on yourself, right? And there's, slow and steady wins the race in this case. And, combined with medication, and, some people I know are anti-exercise, right? But, not exercising can also, pose health risks in other ways. So kind of just exercising in a manageable way will kind of decrease your risk for other things too. So, and there's not one way to do it.
Words to live by.
Yeah.
Well, thank you so much. I really appreciate you sharing your knowledge.
You're welcome.
That was great.
Happy to help. And we're always open to ideas and different things. And I love hearing different things from patients, because it's kind of like everyone, we're all kind of trying to work together to help. So
yeah, we're all learning from one another. Great. Well, thank you so much, Julie, and thank you, Healing Warriors. I hope you found this helpful and were able to get some tidbits that are really going to help you with exercise, with pacing, and yes, forgive yourself, be patient with yourself. You're doing amazing things, and you can do this. You've got this. It's learning how to be slow and steady, as Julie says. Thank you. Bye, Healing Warriors. Bye, healers.